Hello, everybody. My name is Dave. I'm the head of the Communications Committee on the Fellow Senate. If this is your first webinar, that you are welcome. If not, welcome back. I'm going to send 2 quick links in the chat box in case if you guys are on the webinar email list. Basically, we'll let you guys know when webinars are coming up. And then we also have a Google Calendar that kind of updates upcoming. So this is for you guys. It's my pleasure to from University of Colorado. He's the Chief of Interventional Radiology there, and then he's going to be talking about triaging for melanoma. So Dr. Ray,
Thanks, Dave. Hopefully everybody can hear me. Let me know if you can't. So we'll spend the next 45 minutes or so talking about the multiple sort of ways that an IR can treat HCC and really focus on those 3 particular modalities that we use most frequently. Oops. Dave, do I have control? Oh, there we go. Obligatory disclosure slide. So, you know, it oftentimes comes up with our residents, fellows, or even people from other services is there really a best way to treat HCC patients? There are so many options out there, not just IR options, but now with sorafenib, you have medical therapy options and radiation therapy options and surgical options. So the real question is there a best way to treat HCC patients? The answer really is that not really. There isn't a best way to treat them. So I'd like to thank you for your attention and time, and that is actually a much funnier joke in front of a live audience. As I sit in my office with the lights out, it doesn't seem so funny.
I hope so.
Yeah, okay, thanks. The obligatory laugh. So as I mentioned, treatment of liver tumors over the last 40 years has really evolved. In the 70s and 80s, it was easy because you had 3 ways to treat them: surgery, systemic chemo, or external beam radiation therapy. Dave, I'm getting some feedback. I don't know if that was your mic. But the problem is that none of these 3 worked, actually. So the good news is it was a short laundry list. The bad news is that essentially nothing worked if you weren't a surgical candidate. In 2013, we have this laundry list now of things that work and work very well, like transplantation at our institution is really considered the gold standard for treatment of HCC. You'll notice, though, in this list that about half of them really are IR techniques, which is why we've gotten so involved in this space. We're going to talk briefly about sort of the way that IR techniques have evolved over time. I like to split them into sort of generations, 1st, 2nd, 3rd, and 4th generations, and we'll touch briefly about the technique of each of these before we go on to some specific data. So the first generation was chemoinfusion, and that was done either surgically with an implantable pump, and this is kind of what it looked like down here. The surgeon would go and do a laparotomy, divide the gastroduodenal artery, and then stick a catheter up the GDA so it sat in the common hepatic artery, hook that up to this sort of bellows system that he implanted under the skin, fill it with chemotherapy, and then this bellows system would just gradually infuse chemotherapy directly into the hepatic artery. Fairly invasive. IRs got into the space when they would go just sort of a standard angio approach from the femoral artery, go and do a chemoinfusion and pull everything out, go back in and do that intermittently. Currently it's somewhat limited, although you still pick up places that are doing chemoinfusion therapy. Usually it's a 5-FU-based regimen. The next generation started with bland embolization, and bland embolization is simply embolization with particles where you don't give any concomitant chemotherapy or radiation therapy. It's still advocated by some big names out at Memorial Sloan Kettering as the primary way to treat HCC endovascularly. But for the large part, most people have used this now combined with chemotherapy for chemoembolization. The problem with bland embolization is that it depends really on ischemia being the sole effect of treatment of the tumor, so there's no secondary effect with the chemo. Again, largely it's a kind of a holdover from the early days and when chemotherapy agents weren't standardized, until somebody decided, well, let's mix those two. Let's take the idea of chemoinfusion with local chemotherapy effect and blind embolization with its ischemic effect, combine the two and see what sort of an effect we have then. And that really was initially described back in the 80s. It's interesting, back in the 80s, remember, we were kind of considering ourselves just proceduralists. There wasn't really a clinical aspect to interventional radiology. So when chemoembolization came out, it really came out more as a technical description than anything. And the problem is, when you go back to the early papers, everything was all over the map. Because they were describing a technique, what turned out was, we treated 50 patients, and oh, by the way, 25 had hepatoma, and 10 had metastatic colon, and 5 had uveal melanoma, and we used Cisplatin in some, and we used adriamycin in some, and so it was very hard to sort of decipher what it was that was going on from a clinical perspective from these early data. HCC was one of the first tumor types. The first 4 tumor types looked into with chemoembolization were HCC, uveal melanoma, metastatic neuroendocrine tumor, and colon cancer. The bastard child in there is colon cancer because it's the one that isn't really very hypervascular. But it being the most common malignancy in the liver, it was tried as well. And HCC, as we'll see with chemoembolization, really it's sort of the poster child of local regional therapy in the liver. The ablation therapies are a little bit of a sidebar here, and that is tumor ablation came up probably about 10 years later than transarterial therapies, but it's still sort of in that second generation of advancements. And when you do ablation, you can do it by heat, you can do it by cold, you can disrupt the cellular membrane like you do with IRE. And different techniques really have different limitations, and we'll talk a little bit about the different techniques, but for the most part, ablative techniques all have some similar limitations in terms of anatomy. For instance, if lesions are very close to large vascular structures or are very central and you're worried about the bile ducts, then those can be significant limitations for any of these ablative therapies. We have a long experience in the liver with primary metastatic disease and ablations, whether you're talking about thermal ablation by heating it, by freezing it, or cellular disruption. SIRT, or selective internal radiation therapy, is sort of the next generation, and that's really the way to think of it. As I think of SIRT as less radioembolization. I don't know that I particularly even like that term. I really prefer to think of it as a form of brachytherapy, where you're using the beads as a form of delivery rather than as an embolic. So think of it mostly as very localized, very specific radiation therapy. It's dissimilar from brachytherapy for cholangiocarcinoma. You'll hear that term thrown around a little bit. And brachytherapy for cholangio is putting in a tube into the bile ducts and then putting either a rod or pellets down that tube to locally irradiate the tumor, but then everything comes out at the end except your tube. So radiation therapy delivered by selective internal radiation therapy is injecting the little beads, and then the beads stay there indefinitely. There are 2 commercially available devices. They are more similar than dissimilar. Both of them use yttrium, which is a beta emitter. Beta emitters, as you know, have a very high energy deposition over a very short distance. So they're perfect for something like this to inject into the artery. It essentially kills everything that it's going to touch, which is about a 5 millimeter to 1 centimeter range from these beta emitters. They're very small beads, which is beneficial because they go deep into the vasculature of the tumor. And unlike chemoembolization, one of the digs on chemoembolization is that it's never really standardized, so it's difficult to compare one study to another study. With selective internal radiation therapy, you deliver a dose that you tailor specifically to the patient, so it's a little more precise in your delivery. This is an example of the beads. Again, You hear the terms rosin-based and glass-based beads. The real big difference here is this one, and that is the specific activity per bead. It's about 10-fold greater for TheraSpheres, which are the glass beads, which means that you use 10 times as many beads when you're using the rosin-based as the glass-based. That's significant because you end up with more of an embolic effect because you're using more beads. Now, that can be beneficial or it can be a detriment. It really depends on the setting. At our institution, because of this HDE approval, TheraSpheres did a little bit of an end run around the FDA, and instead of getting full FDA approval, they went on what's called a human device exemption, which means that they aren't fully approved if you look at it that way. If you're an institution like ours that has a very robust IRB, then the problem is it's difficult to use off-label. So at our institution, you'll see that we only use TheraSpheres for HCC, and we use SIR-Spheres essentially for everything else. So that's sort of the progression of how things have occurred. This is over the last, chemoembolization started becoming clinically available and used pretty often clinically in the 1980s. So we're talking now about 30 years of data. So we've seen these generational shifts. Every time a new device comes out, there's excitement about it. But the real question is, what is the evidence for these different types of treatment? You'll always read about two randomized controlled studies.
Next time. Okay, good.
Two randomized controlled studies that come up anytime you talk about chemoembolization. It's one of the few things where we had very early level 1 data. The Lovett article looked at 112 patients with unresectable HCC, relatively early underlying liver disease and relatively early HCC. They compared patients in the 3 arms with chemoembolization, bland embolization, and symptomatic treatment, which just meant palliative treatment. And they showed 2-year survival rates of 63% for chemoembo, 50% for bland embo, and 27% for controls. And those were, at least comparing controls to the chemoembo, those were statistically significant. So here's what you end up with. You have a mean survival in patients undergoing chemoembolization of not quite 2.5 years compared to the controls of about 18 months. So about a 10-month survival benefit when you compare chemoembolization and your controls. And that's an important number to remember when we start talking about comparative studies. The second study that came out the same year, they were just a couple months apart, was the Lowe article. That was a randomized control trial of 80 patients. They didn't have a bland embolization arm. They just did chemoembo and symptomatic control. And they also showed a significant 2-year survival benefit comparing chemoembo and control. They analyzed their data a little bit differently, and they showed here relative risk of death in the chemoembolization group of about half that in the control group. So these were the 2 studies that really sort of changed things in our world. Randomized controlled trials, both of which showed a benefit of chemoembolization over controls, which at that point in time was all you had. There were no chemo agents that were effective against HCC at that point in time. Same author did a meta-analysis of randomized controlled trials over a relatively long period. He found 540-some patients compared to about 900 controls treated with either tamoxifen or symptomatic relief. And he showed that arterial therapy led to a significant increase in 2-year survival compared with controls. The other thing that this showed was that when you use chemoembo compared to bland embolization, there really is a survival benefit, while with bland embolization there is not. The other thing that this meta-analysis showed is that when you looked at the overall survival, it actually was equivalent to that reported for surgical resection out to 3 years. And that sort of torqued some people because we've always used the term palliation whenever we talk about our therapies. And now all of a sudden you start hearing words like curative, or you start hearing words like comparable to surgery. And that's still taken, now this was 10 years ago, it's still taken some time for that to sort of hit the mainstream. But it was just about the first time that we started thinking of these therapies as something other than palliative. So the Cochrane, I don't know how familiar you are with Cochrane, but Cochrane is an organization that comes out with recommendations, and they are absolutely married to level 1 data. They don't look at anything other than level 1 data. And they came out in March of 2011 with a Cochrane review. Now, there are about 7,000 or 8,000 Cochrane reviews out there, and one of the ones that they looked at was looking at chemoembolization or bland embolization for HCC. And you know you're in trouble when the Cochrane review starts out with this statement, lack of evidence. And, in their summary, the things that they said is that, their bottom line, the last thing, is that they recommend that chemoembo or transarterial embo shouldn't be used as standard treatment for liver cancer. And the reason why is because even though we have level 1 data for these treatments, they were at risk for bias. They didn't say that there was bias in the studies. They said it was at risk for bias. Well, this kind of got us bothered because ironically, they picked the one thing that we actually have level 1 data for to support efficacy. So there were a lot of responses, both from individual authors as well as from the SIR service line to multiple journals, JVIR, as well as some clinical journals. One of the concerns is when Cochrane speaks, people listen, no matter how, irresponsible it is, sometimes, frankly, with their conclusions, like what we thought was the case here. And one of the concerns is when that happens, are you going to have fallout either from patients, referring docs, or even third-party payers? And luckily, with this particular Cochrane review, it seems that nobody really paid much attention. One of the studies for chemoembolization that really changed things was a study called the Precision 5 trial, which was a trial that compared conventional TACE, which is oily TACE, where you use Lipiodol and mix it with chemotherapy agents, and then deliver that directly into the artery, compared to drug-eluting bead therapy. And drug-eluting bead therapy is little beads that you attach, either ionically or osmotically, a chemotherapy agent to it. And then those beads travel distally into the HCC and act as a depot. So the chemotherapy leaches out over a couple of weeks and locally bathes the tumor in chemotherapy, where standard chemoembolization is really more a first-pass effect. You get the chemotherapy into the tumor, but only cells that are in the particular cell phase that are going to be amenable to being treated with that chemotherapy are affected at that point in time. So you get the embolic effect and you get this first-pass effect from chemo with conventional or oily TACE, but with the drug-eluting beads you get this constant sort of bathing of the tumors. And what this study showed is that there was a trend, although it didn't reach statistical significance, but there was a trend towards improved response with drug-eluting bead therapy. However, when they stratified their data, and this was a relatively small trial, but when they stratified their data, that they actually showed that there were improved outcomes in patients with quote-unquote advanced disease, which is they had defined as Child's B, ECOG1, bilobar or recurrent disease. Well, I don't know about your institution, but at our institution, everybody is Child's B or C, and ECOG 1 or 2. So at that point in time, and this is back in about 3 or 4 years ago, we converted over to drug-eluting bead therapy completely. So at our institution, we don't use any oily TACE anymore, except in very select circumstances. So the Precision 5 trial, one of the things that they showed is that alopecia or side effects from the chemotherapy were significantly lower with the bead group than with conventional TACE. I have to admit, this 20% rate of complications of alopecia in conventional TACE seems very high to me. So I'm not sure that you know how much we can really take from this. And if you've ever seen me in person, you'll understand that I don't really put much credit in alopecia anyway. But that's just me. In terms of DEB TACE in advanced disease, there have been a couple of articles, 3 actually, that have come out. This was the first one that came out. I think this was the Emory group, if I'm right. And they looked at patients with relatively advanced disease, and we'll talk about this a little bit later. But they looked at about 120 patients. They showed that they had a significant number of adverse events, but none that were greater than grade 3, which is the NCI designation for significant or severe side effects, and no deaths. They showed an overall median survival of about 13.5 months. Now remember, with the Lowe and Lovett articles, they had about 18-month survival, but they were kind of cherry-picking patients who were much healthier. So these patients have much more advanced disease, both advanced liver disease and advanced HCC. One of the things you have to remember in this patient population is that many of these patients don't die from their HCC. Many of these, if it's treated, many of these patients die from their underlying cirrhosis. So a 2-year survival benefit in somebody with HCC and advanced cirrhosis actually is significant. If you don't treat these patients, you can expect their life expectancy to be somewhere between 3 and 6 months. We looked at our data here as well, a little smaller study. We actually had some patients with BCLC C and D disease, and we had about an 18-month survival. And as I mentioned, there have been a couple of other articles that have come out as well that show that all of a sudden we're expanding drug-eluting bead therapy or chemoembolization in patients who have more advanced disease than those we've been treating in the past. Switching gears now from chemoembolization to RFA, the RFA data are very compelling. This is a review article that actually looked at 5-year survival rates of patients who received RFA is the sole first-line therapy, so not combined with transarterial therapy, for example. And if you start looking at these overall survival rates, they actually approximate, if they're not better than, surgical resections. So again, all of a sudden, we started using words like curative, especially with ablative therapies. And it's interesting that that now that surgeons do some ablations as well, words like curative intent are coming out in the surgical literature when they're talking about ablation as well. There was one study that directly compared this, and kudos to the surgeons because this actually came out in their literature. And they had a randomized controlled trial comparing relatively small HCC, those who underwent resection versus those who underwent RFA, and they showed no statistical significant difference. There was an immediate response from the surgical community with some concerns about the article, particularly in terms of design, etc. But for the most part, it's a pretty robust study, and again, it's one of the few studies that directly compare surgery and RFA and showed equivalence. One thing I want to mention, at many institutions, you'll notice that people use imaging solely to diagnose HCC. So HCC oftentimes is not biopsied, and the reason for that is there's about a 4 to 12% risk of tract seeding. So you biopsy it, and then when you pull out your needle, you drag some tumor cells with you, and those tumor cells can actually seed outside of the liver, in the chest wall, at the diaphragm, in the peritoneum, etc. And unfortunately, then you've taken the patient from being a transplant candidate, which is the best way to cure HCC, to not being a transplant candidate. So people got away from biopsying, and that's why you'll see in the imaging literature all of these ways to diagnose HCC without a biopsy. So the question comes up, well, what about RFA or any ablative therapy? If you do an ablation, what's your risk of tract seeding? And as it turns out, the risk of tract seeding is actually very low. Why is that? It's a bigger device. You'd think you'd be drawing more cells. Well, the reason for that is that oftentimes people will ablate the tract on the way out. So you use relatively low energy, but as you pull your needle or antenna out, you ablate the tract so you kill any cells that you're dragging with you. So at this point in time, most reports are more in the 0.5% range than in the 4% range. So the idea of tract seeding as a contraindication to doing RFA is really doesn't have much merit. Radiation therapy, or SIRT, largely Riyadh Salem out of Northwestern has been responsible for starting radioembolization as a significant treatment line. There are a lot of places now doing it. Indiana University, for example, does a ton of it. But most of the time you'll see things coming out of Northwestern in terms of significantly large studies. This was a study that came out in gastroenterology of about 300 subjects, average of 1.8 treatments per subject, and they showed overall time to progression, of about 8 months. Toxicities, one of the things that you'll hear, you'll find out that there are chemoembolization camps, and there are radioembolization camps, and there are ablation camps. A lot of it is local. At Colorado, for example, we do about 180 chemoembos a year and about 50 SIRTs a year. So we're kind of a chemoembolization place. Dan Brown is a big chemoembo guy at Jefferson and now at Vanderbilt. IU and Northwestern are big radioembolization places. And you know what? If there was one way to do it, we'd all be doing it that way, right? So take a little bit of a grain of salt if you read something out of my institution, where we definitely have a chemoembo bent. If you read something out of Northwestern, they definitely have a radioembolization bent. But one of the things that the SIRT camp usually talks about is the fact that their treatments are less toxic than chemoembolization. I would tend to agree with that, but when you look at the data, they get almost as much post-embolization syndrome as patients undergoing chemoembolization. So it's not the benign sort of magic bullet, nobody's going to get hurt by it type of treatment that we used to think it was. Another study out of Northwestern looking at portal vein thrombosis. Patients with portal vein thrombosis have a very bad prognosis in terms of survival, overall survival. They looked at their data and had about 37 patients with portal vein thrombosis, including 12 with main portal vein thrombosis, and they had a significant response rate of about 70%. If you look down at their survival curves, down here is main portal vein thrombosis, branched portal vein thrombosis, and no portal vein thrombosis. But if you draw your line out here, you can see that even for portal vein thrombosis, they had about a 9-month survival, median survival, which is very impressive, actually. These patients usually die within a matter of weeks to a couple months. So we have all of these papers that come out, and there are chemoembo papers, and there are yttrium papers, and there are ablation papers, and whatever. But what about direct comparisons? How often have we gone into the literature and actually directly compared one to the other in terms of trying to answer this, is there one way better than another way? Northwestern group again, Bob Lewandowski took about 150 patients and 125 patients with yttrium and chemoembolization, and they showed that the median survival favored yttrium, although I don't think this actually reached statistical significance. One thing that they did show, though, when they stratified their data, is that lesions that were outside of Milan criteria, so patients who were not transplantable, more of those lesions, significantly more of those lesions, were downstage with yttrium than chemoembolization. So maybe one of the most important lessons out of this for me was that even though the survival didn't quite reach statistical significance, this did. So if you're planning on potentially downstaging a patient, is it reasonable to think about yttrium? I don't think I have these slides in here, but we looked at our own data at CU with downstaging patients with drug-eluting bead therapy and actually showed a 77% downstaging rate. This is coming out in JVIR shortly. One caveat, though, is that Bob used a different imaging response. He used RECIST, where we used modified RECIST, which is definitely more generous. So I don't think that you can walk away with that, 58% versus 77% comparing yttrium versus drug-eluting bead therapy. But I do think that it's out there now that drug-eluting bead therapy might be a good way to downstage these patients as well as yttrium. Another Northwestern study, this is interesting. This was in 2011 and Bob's was in 2009. So I'm assuming that there are some patients that crossed over into both studies. The median survival was not statistically significant in this study, but time to progression favored SIRT over yttrium. And interestingly, when they did a post hoc analysis, they basically showed if you're going to show non-equivalence, or if you're going to show equivalence, you need about 1,000 subjects. And I don't know if that was in each arm or total. Either way, it doesn't matter. It's a lot of subjects. So to me, when I see something like that, I kind of think, well, gee, if you need that many subjects to show a difference or not show a difference, then maybe they're pretty equivalent in some ways. Study out of Emory kind of looked at the same thing, and the bottom line for this study is that these were equivalent treatments. And then another one out of Case Western, again a smaller study, but showed no significant difference in overall survival, although the complication rates in this study were higher in the chemoembolization group. And then finally, the Mayo group looked at these patients, and it showed that actually, ironically, yttrium was more likely to cause fatigue, so complication rates were a little higher in the SIRT group rather than the chemoembolization group. So why do we choose one modality over another? Why do we at CU do 180 chemoembos and 50 yttriums and 10 ablations a year? You know, what is it that makes us do that compared to some other places that you guys are at? Well, there are some common arguments. Tract seeding. Well, we don't want to do ablation because we don't want to seed the tract and make the patient no longer a transplant candidate. Well, we already kind of addressed, and that, by the way, is we can't get our transplant surgeons here to get away from that argument, even with the data. But you've seen, and I've shown you that the data, the tract seeding is probably on the order of about 1% or even less when you ablate the tract on the way out. Ablation techniques are too complex to perform uncommonly. I've heard that argument. I've even made that argument. And I think that probably was the case back in the day when, radiofrequency ablation, you had your cool tip probes, that you needed to have a pump, pumping cooled saline through the inner part of the needle. It was a kind of a bulky thing, especially if you were using a switch box as you were ablating, using multiple needles at the same time. This used to be the setup. You've got your switch box, you've got your generator, got all sorts of stuff that can go wrong. Nowadays, and this is one example, we're using, I don't even know if this is the new wave, I think it is, we're using microwave in most of these patients, and it's a kind of a plug and play. You almost can't, well, I shouldn't say that. It would be very difficult to make a mistake with the current technology. What about yttrium? Yttrium programs are too difficult to set up and maintain, and I will admit that they're difficult to set up. You start doing things when you do radioembolization that we're not used to. We're not used to looking for supraduodenal arteries. You're used to embolizing right gastric arteries or things that make yttrium treatment much safer. We're not used to doing dosimetry in the planning. That's usually in the realm of radiation oncologists. So it is difficult to set up, and it is a little bit difficult to maintain. I'm going to put in a plug here for a course that the SIR puts on. It's a Y90 course. Last year it was an advanced course. The 2 previous years it was a basic sort of introduction to Y90 course. So the courses are out there, plus a course at our annual meeting. There's significant opportunities for education as well. All imaging-based therapies are palliative only, so why bother? Well, I think we've addressed that. Some of these treatments really now can be thought of as curative. Or if they're not curative, they're palliative to the point where you take somebody with a very horrible prognosis. HCC is a horrible disease. And, 18 months might not seem like a lot unless you're starting at 6 months. So I think the palliative argument kind of falls on deaf ears these days. TACE has higher rates of post-embolization syndrome, so that's why I use Y90 all the time, for example. That's an argument you hear. I do think, my own personal opinion is that Post-embolization syndrome with chemoembolization occurs in probably 100% of patients. It's just a matter of degree. How bad is it? Do they just feel like they've got a little flu for a couple days and then they get over it, or are they bedridden for a couple weeks? But the data really do suggest that although it's a higher rate of post-embolization complications with chemoembo, we are seeing more of it in the yttrium population because I think we're looking for it a little bit better. SIRT's far more expensive than the other options. Now I'm going to touch on that in a second here, but you hear that a lot. Why would I do the expensive one when the cheap one is just as good? And again, I'll talk about that in a second. So these are all kind of the common arguments that you hear at your institution or my institution or at the annual meeting or whatever with why some people have a preference for one over the other. What are the real reasons? Well, I think the real reasons aren't those stated reasons. I think the real reasons have more to do with bias. Institutional bias, there's a personal bias against one or the other, either because you've had patients who haven't responded that well, or they had bad complications, or it's too much of a pain in the ass to set up, or whatever it is. You can have a lack of infrastructure. That's particularly true with Y90. If you're going to start a Y90 program, you'd better be absolutely certain that you've got everything in place, and that includes your radiation safety officer and licensing. And then there's research agendas. I'll be upfront when I say, one of the reasons we do a lot of chemoembo here is because, we do have a research agenda, and if patients don't like that, then I'm happy to send them down the street to Charlie Nutting for more yttrium. Definitely operator preference, and now we're seeing, as IRs get more sort of out there in the community, we're seeing some patient preference as well. Let me talk over the next couple slides about cost. We did a cost analysis specifically looking at these three modalities in the treatment of HCC, specifically to try and address the idea of, well, is yttrium really that much more expensive, and can we justify it? So we did it from the payer's perspective. Whenever you do a cost analysis, the first thing you have to determine is cost to whom. And our cost was, well, what is it going to cost Medicare for a patient to undergo RFA or chemoembo or yttrium therapy? We modeled it, and I'll talk about that in a second, and we made sort of some assumptions that are pretty standard out in the community. So what we showed when we did our simple decision tree analysis is that RFA came out, this is per treatment, came out at about $8,500, chemoembo at about $8,800, and SIRT at about $30,000 for one treatment of SIRT. One of the reasons this was so expensive is because, as you know, you have to do your planning angiogram first. So this is really, even though it's one treatment, it's really two procedures. However, when we went in and modeled it, and by modeling it, what you do with a Monte Carlo is you look at all of these variables that go into your model, like age of patient and underlying, what is the cost? What is the cost range? Are you at the high range or the low range? So you use all these variables and vary them accordingly, and then run your model. We ran it 100,000 times, and then you come up with an average. And when you Monte Carlo it, you can see that what happened is RFA got a little more expensive, but chemoembo jumped up significantly and kind of started to approach yttrium at that point in time. One of the things about a Monte Carlo is that it ends up giving you, at the end of your analysis, it ends up giving you a distribution of preference or a distribution of dominant strategy. And out of 100,000 times we ran the model, 100,000 times RFA came out as the least expensive. So one of the few times where I think you can say definitively, of the three, RFA is the least expensive. However, when we looked at the distribution of the results for comparing yttrium with chemoembo, a third of the time yttrium actually came out to be less expensive than chemoembolization. So why is that? Well, then you have to go backwards and look at your variables and what's called a sensitivity analysis. And the only thing that mattered was how many times do you have to do the chemoembolization and how many times do you have to do the yttrium. So if you can figure out a way to do chemoembolization once or twice instead of 4 or 5 times, it actually would be significantly less expensive probably than yttrium. So our conclusions with this study is that RFA is the least costly of all three procedures, essentially 100% of the time, but that TACE is less costly than SIRT, but there are instances when that's not true. The next step for us for cost analysis is using the same model that we developed for this to compare, okay, now we have the three comparisons between the three IR procedures. What is it compared to surgical resection? Or more importantly, to my mind, what is it compared to sorafenib? Sorafenib is a horrific drug. It has terrible side effects. Every study you look at that has sorafenib in it, people are either being dose reduced or they're being taken off the drug because it's so horrible to patients. And parenthetically, the study that showed that sorafenib works in patients with HCC imparted a 10-week survival benefit. Remember, our first two studies, the Low and Lovett study, showed about a 10-month survival benefit. So you're giving this bad drug that seems to be very expensive for a 10-week survival benefit. And then finally, what we would like to do is do a true cost effectiveness. Right now we have the cost side, but as you know, it isn't okay. It costs $30,000. Well, if it costs $30,000 and gives people a month extra of life, and that month is in the hospital, that's a different thing when you compare to, well, a $30,000 bill that gets somebody back home and functioning for 2 or 3 years. And that's where the effectiveness or the utility metrics come in. So those are our next steps, and those are what we're working on currently. This is the best part of any discussion is, trying to figure out, okay, those are the building blocks that we've had so far. Where do we go from here? So what are the future directions with HCC treatment and IR modalities? There are some ongoing comparative studies out there. Northwestern has a study comparing conventional TACE and SIRT. Primary endpoint there is time to progression. It's interesting, isn't it? Now all of a sudden we're starting to even talk like oncologists. Survival is one outcome, but time to progression, which is what most chemotherapy trials use, is the endpoint both in the American study as well as the Dutch study here. And this is looking at patients with BCLCB, and I think BCLCB up here as well. To me, some of the most interesting areas right now are going to be combining some of our therapies. We've always thought of these therapies in a silo, and I don't think that we need to. I think we've grown beyond that. And the real question is, well, what is chemoembo plus plus radiofrequency ablation do, or microwave ablation? And there are some studies out there now that show that there does seem to be some significant benefit by stacking these one on top of another. How about if you do an ablative therapy with Y90? Or even better, how about if you do sorafenib with chemoembo? These are all studies that actually, I don't know about the second one, but the first and the third are studies that are either being performed currently or being analyzed currently. So time to stop thinking of these therapies in a silo and start looking at them as another way to treat this disease process. I do think that we need to show value in our treatments, and that's where comparative effectiveness studies come in. Doing direct comparisons of, for instance, sorafenib versus chemoembolization or surgery versus RFA, where we can show value, whether it's improved survivals, decreased complications, or less cost. And then finally, this idea of increasing the role of local regional therapies. If you look at, this is the BCLC classification, and BCLC, everybody likes to use it because it's not just a classification scheme, but it also gives you a recommendation of where to do what. And chemoembolization, and I would probably put radioembolization in here as well, has always been under this intermediate stage disease. Patients with early disease either undergo resection or ablation, transplantation, or other ablation if they've got multiple nodules. But transarterial therapies have always sort of been in this ballpark. We've seen, though, that with some of these studies that have come out, and these are all in the last 6 months, looking at patients with advanced disease, C and even some D patients, that some of these therapies, well, you can see where I stole that from, particularly transarterial therapies, are starting to fold over into these other stages, such as advanced disease. And I think that's where we're going to see a lot of action, a lot of activity in the next 2 or 3 years, is extending the reach of interventional treatments to these areas that up till now have been kind of verboten. By the way, the medical oncologists are doing the reverse to us. They're looking at sorafenib with intermediate stage or earlier stage disease. So we are going to see some blurring of the lines over the next couple of years, but here's hoping that we're going to still kind of have the upper hand. So those are the 3 areas that I look at to, if you're looking for a project, I would kind of focus on these 3 areas over the next 2, 3, or 5 years. I think that's where we're going to see the most research being performed. So last couple slides here. Back to the original question, is there a best way to treat HCC? Well, I think the answer to that is that sometimes. I do have to get on my soapbox a little bit, though. And we're as bad at this as CU as anybody else, because we are a chemoembo factory. The bottom line is, especially for you guys to think about, you need to learn all of these procedures, and you need to have each one in your toolbox, and you need to be willing and able to use each one liberally. Use them outside of sort of the standard areas where we've always thought of them as being pigeonholed. These are very good therapies, especially when you compare them with the other therapies that are out there, like sorafenib. And think to yourself, if I don't do the procedure, what is the cost to the patient if I don't do the procedure? And oftentimes what you're left with is, well, they're going to go home and die. Because if your patient has a total bilirubin of 4, there's nobody who's going to give them sorafenib in that setting. So it ends up being a judgment call. But the bottom line is, if you have the ability to do all 3 therapies, you have a much bigger toolbox, and you can tailor it according to each individual patient. So is there a best way to treat HCC? Well, this is one person's opinion. If I'm looking for a cure, I would ablate. I think that the likelihood you're going to get complete tumor kill is significantly better with ablation than with chemoembolization or yttrium. If you're looking to bridge the patient to transplant, or you're looking for survival benefit, whether you're talking about chemoembolization or yttrium, I think really kind of depends on the institution that you happen to be at. But I think both can be used effectively as a bridge to transplant or survival. If you have extensive bilobar disease, or you have main portal vein thrombosis, at that point in time, I send my patients to yttrium instead of going the chemoembolization route. And then, of course, if you have somebody who doesn't respond to one form of therapy, so you start with yttrium, it doesn't work, try chemoembo. Totally different mechanisms of action. There's no reason to think that if you didn't respond to one transarterial therapy, that you're not going to respond to another transarterial therapy. So this is the algorithm that I typically use. If the patient has very advanced disease, oftentimes we'll stop, or at least have the discussion with the patient about the risks of doing chemoembolization in this type of patient population. If the patient is not a transplant candidate, and there are relatively few lesions and they're all small, I put RFA here, but we actually do microwave at this point in time. Don't forget that another way to treat these is with direct alcohol injection. That can be particularly helpful if you're in a difficult anatomic position for the thermal ablative therapies. If the patient is a transplant candidate, or if they have multiple lesions or large lesions, and they don't have extensive bilobar disease or PVT, then I go the chemoembolization route. The only time at this point in time that I do conventional chemoembo with Lipiodol is if I'm not sure that I'm dealing with HCC, because Lipiodol can be helpful in diagnosing HCC. If the patient does have extensive bilobar disease or significant portal vein thrombosis, then I go the yttrium route. Now, please understand, this is one person's opinion. You ask 10 interventionists, you're going to get 12 different opinions on the way to treat these, but this is the way I do it in my practice. That's what I have. I'm happy to, I don't know how this works in terms of questions. Dave, I don't know if you send them to me or if people can send them to me directly.
Sure. So sometimes people, first and foremost, thank you, Dr. Ray. That was a very great talk, nice review, going over algorithm and the treatment strategy you guys have at Colorado. You guys feel free to unmute your microphones by clicking and asking questions. It might be easier to type it in. We do have one coming, so let me ask this question from Kavi. How do you approach patients with arterial portal or arteriovenous fistulae?
Right. So, and that's a great question. So HCC is known to have arterial portal fistulae. You can do a couple of things with those. If they have significant arterial portal fistulae, everything that you inject is going to stay in the liver, right? Because it's just going to go into the portal vein and then fly distally. You won't get the effect that you're looking for, the tumor potentially, because you're going to bypass the tumor, but it's going to stay in the liver at least. As opposed to hepatic artery to hepatic vein collaterals, which you can also have. That's why we do technetium MAA shunt studies in everybody pre-yttrium, because we don't want there to be too many hepatic artery to hepatic vein shunts where your yttrium is going to end up in the lungs. And if it ends up in the lungs, then you run the risk for radiation fibrosis. In chemoembolization, we don't really worry about that so much because, think about it, the lungs are still going to see way less chemotherapy than they would if you were to give it systemically anyway. So in the chemoembolization space, we've never really worried about hepatic artery to hepatic vein shunts, except that you're not going to get enough therapy to the tumor potentially. There was a study or an article that came out, the guy's name is May, M-E-I, and it was in seminars about a year ago, where they describe what they do for patients who come in with hepatic artery to hepatic vein shunts and the size of the bland embolic particle that they use. And that's usually what most of us do. We try and shut down those shunts initially with a bland embolic and then chase it with your chemoembolization or, I guess, potentially yttrium therapy. So take a look at that article, and that'll kind of give you an idea of technically how to do it. But the bottom line is usually what people will do is they try and shut down those fistulae with bigger sized particles and then chase it with your chemoembolic or yttrium therapy.
All right. We have another question coming in. What, in your experience, what are most people using for colorectal metastases to the liver? Doxorubicin or irinotecan?
Yeah. So and again, every institution is different. If we have colorectal mets, we go right to yttrium. Oh, I should say if we have any mets, we go right to yttrium. Doxorubicin doesn't have very much effect at all against colorectal mets. The only other thing you can bind for drug-eluting therapy is irinotecan. And the problem with irinotecan is it hurts, and it hurts badly. I don't understand why that is. It's the same size bead, so it's not an ischemic effect. But the patient can have very significant pain, even on the table. And to me, the results for for drug-eluting bead therapy in colorectal mets don't really approach those that we're seeing in the yttrium literature. So I personally reserve chemoembolization for patients who have failed yttrium or who for some other reason, like maybe they've got too big of a shunt, can't get yttrium. But I rarely do chemoembolization these days for colorectal mets.
We have another question. In your algorithm for the ablation section, you had RFA. Some people are asking when you consider IRE or other like cryo, or how do you choose specifically which sort of ablation method you use? Sure.
So IRE, irreversible electroporation, uses electricity to disrupt cell membranes, and it's very interesting technology. The technology comes from reversible electroporation, where you expose cells to electricity, disrupts the cell membranes temporarily in order to allow drugs to get into the cell. IRE is irreversible electroporation, where you expose to the cells to an electric current, it disrupts the cell membranes permanently, and then the cells die. So there is no heat that's generated. The benefit of that is that there's this thing out there called the heat sink effect, where if you have a tumor that's sitting right next to a large blood vessel, you have relatively cool blood coming through, and that bathes the outside of the tumor, or the tumor that's adjacent to the blood vessel, and keeps it relatively cool. So you get a very poor tumor kill adjacent to large blood vessels. It doesn't hurt the blood vessel, but you don't get a good tumor kill. So IRE gets away from that. It also might be safer in that it might not damage biliary ducts, which are very prone to thermal injury. The problem with IRE is you have to have two electrodes, and they have to be very precisely placed. So it's still kind of in its nascent phase. Not a lot of places are doing IRE because it's technically very difficult to do. So you're left with the heat therapies like RFA, microwave, chemical therapy like alcohol or cryo. There aren't a lot of places doing cryo in the liver anymore, and that's simply a function of, it's personal preference as much as anything. In the past, cryotherapy used to have a significant incidence of what's called shock liver, which is, you can go into liver failure, but it also causes metabolic disturbances throughout the rest of the body. But another problem with it is that a certain number of livers cracked, split, and then patients would have, devastating bleeds. That was back in the day when we were using 24 French devices rather than 17 gauge devices. So the idea of cracking the liver anymore with cryo is not very, it's just not very common with today's technology. That being said, still relatively few places are doing cryo. In terms of the heat-based therapies, RFA versus microwave, a lot of it's personal preference. We like microwave because you don't have to ground the patient. RFA technology is exactly the same technology as a Bowie knife. So you have to put a grounding pad on the patient and have a complete circuit throughout the patient. The single biggest cause of lawsuits against operators using RFA is not complications from the RF in the liver. It's actually grounding pad injuries. People can get very significant burns on their legs, for example, like third-degree burns that never heal. So there's that issue. There's the heat sink issue seems to be worse with RFA than microwave. So those are the two reasons why we've gone largely to microwave. And then finally, the chemical ablations like alcohol you would use in a place where you are right next to a big blood vessel and you're worried about heat sink, or you're worried about being too central and having a thermal injury to a central bile duct and causing a problem with the central bile ducts. So there you might just want to stick a needle in and chemically ablate with alcohol. So there are different reasons to use. A lot of them are operator preference, but a lot of them have to do with anatomically where lesions sit in the liver with when you might want to use one technology over another.
As a follow-up to that, we have a couple of people asking if you know of any specific studies that look at alcohol ablation only.
So look up Lencioni. Lencioni did a comparative study actually comparing alcohol and RFA ablation, and in those studies really showed improved results with RFA over alcohol, and that really shifted the pendulum, especially in Europe, where they were still, probably for a couple of years, they were using alcohol longer than we were using it in the States. Everything started out with alcohol, and then eventually went to the thermal ablative techniques. But there was a study, and I think it was in radiology, I can't remember, but Riccardo Lencioni did it probably 10 years ago now. But just punch up RFA, alcohol, Lencioni, and it'll pop up.
Okay. A couple more questions. How are we doing on time, Dr. Ray? Can you bear with us for a couple more?
Sure, yeah.
Okay. I'll ask there's some two questions. We have a couple of people asking what size drug-eluting beads do you use and why, and if you could elaborate on how you select DEB TACE over Lipiodol for your HCC.
Sure. So to take the second question first, we use drug-eluting bead therapy in 95 to 99% of our patients, and the reason why goes back to that Precision 5 trial, which was the first trial that directly compared the two. when they substratified their results and looked at patients with advanced liver disease or advanced tumors, patients did better with drug-eluting bead. The results were better with drug-eluting bead therapy compared to Lipiodol TACE. Almost every patient we see, if not every patient we see, has either advanced liver disease or advanced tumors. So because of our patient population, we converted over to drug-eluting bead therapy almost exclusively. But that's a function of here. If you're seeing patients with early-stage disease, I see no reason why you couldn't or shouldn't use conventional TACE. In terms of size of the beads, some of its operator preference. The idea, of course, is that the smaller the bead, the deeper it gets into the tumor, and potentially the more beads you can get in and maybe deliver more chemotherapy. So I tend to use 1 to 300 size beads, 1 or 2 vials depending on the size of the tumor, and we load all of our beads, each vial with 75 milligrams of doxy. You can load it with either 50 or 75. There's a new bead out there called the M1 bead, and that's about I think it's 40 to 120 microns or something like that, so it's the next size even smaller. The reason I haven't gone to that is simply because it's an order of magnitude more expensive, and I haven't seen anything that's convinced me that the results are better. So I stick with the 1s to 3s. Rarely, if I'm doing like a lobar therapy, somebody with just a huge tumor burden, I'll start with 1s to 3s and then give a vial of 3s to 5s. But for the most part, the smaller the bead, I think the better. And there was, interestingly, just an article, I think 1 or 2 months ago in JVIR that looked at complications comparing the small beads, 100 to 300 versus the 300 to 500. And you would think with the more distal embolization and the higher ischemia that you would actually have more complications with the smaller beads. But this study showed just the opposite. They actually showed more complications with the larger beads. So, one more reason to go small. Any other questions? I think we lost our moderator. Are you there?
Last question, then we'll let you go, Dr. Ray. How does your management work for neuroendocrine tumor metastases to the liver?
Right. So the real question you should ask yourself initially, I think, is what is the goal of your therapy? If the goal of your therapy is symptomatic relief, I think you can use anything, including bland embolization, by the way. That's probably the one instance where I might consider using bland embo. If you're looking for a survival benefit, or if the patient can't get other forms of primary therapy like chemotherapy for their neuroendocrine, I tend to go these days to yttrium, and it's getting back to that whole idea of extensive bilobar disease. We still do largely lobar therapy for yttrium and selective therapy for chemoembolization. Some of that is historical as much as anything, quite honestly, but for metastatic neuroendocrine, my algorithm would be to start with yttrium and go to chemoembo or bland embo even potentially if you're looking for symptomatic control. One of the benefits of treating patients with neuroendocrine tumors, they usually don't have underlying liver disease, unlike the HCC population. So they aren't going to die from their underlying liver disease like HCC. So you're trying to bridge these patients for 10 or 15 years they can live with their mets, as opposed to HCC patients who generally will die from their underlying liver disease within a few years.
All right. Well, thank you again. Thanks everyone for joining. Thank you, Dr. Ray, for giving us a good chunk of your time. And I think I speak for everyone when I say when your IR career is coming to an end, you have a promising future as a comedian. So.
Yeah, I'm not sure about that. All right, guys, thanks. That was fun.
All right, take care. Thanks. Have a good night. Bye.